is Melissa with HD Support and Care Network, and we are with Dr. Johan Samanta. He's an MD PC, and this is Lunch with Docs HD. And first, I'd like to thank PMD Alliance and Teva Pharmaceuticals for giving us this opportunity to come before our HD community and present amazing, incredible special guest speakers. Johan Samanta is one of those. He is a neurologist and movement disorder specialist in Phoenix, Arizona, and is a clinical associate professor of neurology at University College of Medicine. He also serves as the director of movement disorders research at Banner Good Samaritan Regional Medical Center, and he's been the principal or co-investigator of 22 past and current clinical trials in Parkinson's and essential tremor, dystonia, and stroke. So we are very, very fortunate to have Dr. Samanta with us today. Our topic today is going to be advocating for yourself with your doctor. This is really an important topic. And I'd like to preface before we get started that, you know, with our HD folks, sometimes the caregiver is the one who's gonna do the advocating, but it's always a good idea to try to teach our HD patients, our HD individuals, how to advocate for themselves too. But sometimes, you know, it's a little difficult. So Dr. Samanta, thank you, welcome, and take it away.
Oh, well, thank you. Thank you very much for having me. It's my pleasure to be here, and hopefully I can provide some useful information or some helpful tips. You know, I think with any chronic condition, I think it's, you know,
vital that, you know, you be your own best ambassador, your own best advocate. It's obviously having, you know, family members that support you, having other caregivers or providers that are able to go with you is helpful and important, and certainly can be necessary if, you know, as depending on the state of your health and your condition. But being your own advocate is always, you know, in your best interest. And it sounds like sort of a very big thing, but it really comes down to some fairly simple things. And it's, you know, as simple as, you know,
albeit maybe sort of self-evident things like, all right, you know, make sure that you come to your, you know, that when you've got an appointment, that you have a good plan to get there, and that you make it, you know, to your appointments on time, and with if you can, a little bit of time ahead, so that you've got a chance to sort of, if there's any new paperwork from the office, you get that taken care of, and that doesn't eat into your appointment time. And then even before you get there, have a list. Even you don't necessarily have to write it down, but I think that helps. Have a list of issues you'd like to address with the doctor, and some of them, you know, they may or may not feel like they are directly related to your Huntington's, but they might be. And so if you're not sure, at least bring them up, have them there on your list so that you don't forget about them, and that you kind of have thought that way too. You've kind of thought about, well, how do I want to explain what's going on? And that could be sleep, it could be pain, it could be, you know, it could be things that are not maybe the most obvious Huntington's symptoms. And because we know for some people with Huntington's, concentration and memory can be affected. Having that list to look at and refer back to is really, really valuable and important. And then don't be afraid to ask questions, or if there is something the doctor wants you to, you know, mentions or suggests, and you didn't really understand, or you're not sure about, you know, well, what does that really mean? Whether it's, oh, I want you to start this kind of therapy, or, you know, we want to talk about mobility devices, and, you know, and you're not exactly sure, well, what does mobility devices mean? Never be embarrassed to ask, or to stop the conversation and say, well, okay, what is that term? Or, you know, or what does, choreoathetotic movement mean? If they throw a term out there that is it just doesn't sound like English, to you, then don't be afraid to say, I'm not really sure what that means. Are you talking about my movements? Are you talking about something else? Because it's the doctor's job, not just to give you, to make a diagnosis and give you medications or prescriptions. It's to help educate you and help you understand what's going on with your body.
Can you give us some tips on how to prioritize lists of things that need to be covered? Because a lot of times we may have a list of 20 things, that we're concerned about or need help with or want to ask the doctor. How do we prioritize these things that we need to talk to the doctor about?
Sure. And it, and the way you prioritize may be different for different people or different situations, but I always think of, simple way of looking at it is, all right, is there, on this list, is there something that you just, I need this fixed tomorrow, or I need this addressed, tomorrow? What is the most, what is the issue that's either causing you the most frustration, keeping you awake at night? Those are the ones, and, that I always would say, let's start with those, the hot button, the red light ones, and then, then go down from there. Are there ones that you think, well, all right, this isn't keeping me up at night, but maybe you've heard or you're worried that this is something new, so something new or a change. And sometimes those are going to be one and the same, and that's simple enough. But, things where you say, gee, this hasn't been really terrible, but I've noticed, and I didn't notice this before, but, now I fall asleep a lot more easily during the day. Or, gosh, I really, I notice it's more awkward getting in and out of a car, and that it's not a big problem, but it's new since we saw each other last, those sorts of things. I think that's kind of the way I put those kinds of things up towards the top. And then, gosh, if it's just something where it would be nice to know about this, or I've heard, I've heard about, someone else is doing this or that, those are the ones you kind of, if we have time to get there, then great. But I want to make sure that these things that maybe are causing me more distress, and it doesn't have to be physical distress. It could be just that these are things that are worrying you, and they may not be pain. It may not be that your balance is bad right now, but you've noticed that it's changed and you're worried about what that means. And I think those are the kinds of things that I suggest you put on the top. Or in your caregiver situation, and maybe you need to make the doctor aware of that, and the doctor may be able to help with getting you some more support, and so things like that might directly impact your day-to-day function.
I have a couple questions for you.
Okay.
One of the questions came in, and she's asking, how do we know what things to ask a movement disorder specialist as opposed to a regular internist?
Well, so I think so for movement disorders neurologist, I think you really kind of should be able to ask anything that you think, whether you know for sure it's your Huntington's or whether you think it might be related to Huntington's. This is, that's the person you're supposed to be, who's supposed to be your expert, your go-to person. So it doesn't mean you can't ask them about your blood pressure, because it's possible if you're maybe your low blood pressure, if you're having that issue, maybe that might be part of something else, but it also could be part of the Huntington's. And the only way to know that is by asking your movement disorder specialist. That's really why they're there. So I think, that's the person that I guess, if you're even thinking, gee, I wonder if, then that's your starting point when it comes to who you should be asking questions to. And hopefully, the way most of most movement disorders specialists sort of work is, we have longer appointments, and so, part of the reason for that is so that we can get into more in-depth details about what's going on, and so that you can ask more questions, and so we can ask you more questions. So, but I think it's definitely not a thing of, are there things I shouldn't be asking? I think, if you think of it and you think it might be important, you should be asking your movement disorder specialist.
Right. So like if it's a matter of body functions, bowel, bladder, things like that as well.
Absolutely. So, we spent a lot of time talking about constipation, bladder issues, and every, in some situations, the answer still might be, I'm not sure if this is directly part of your Huntington's or not, or I'm not, this might be part of your Huntington's, but I think we should have you see a urologist or a gastroenterologist, or we should maybe also check in with your internist and see what they want to do, whether you might need a GI, a scope or some kind of radiology test. But I think, Huntington's is certainly, we recognize Huntington's affects much more than just movement and balance and things like that. It affects your whole body. And we know that things like, increased bladder urgency or frequency can be part of it, because that relates to the autonomic, nervous system. That there could be more issues with maybe constipation in some people with Huntington's, which is also true with a number of neurological conditions. So even though they're technically different systems, they're still connected, or may still be, they may still be part of the whole picture of Huntington's. So it's never, I really don't think, you're never wrong to ask.
Can you explain the brain function with these systems, the bowel and bladder systems?
Sure, I can try, and it is definitely, it's complex, but we do know, so while the primary changes in Huntington's are in an area, a circuit called the basal ganglia, and particularly an area called the caudate nucleus. Well, that circuit has connections to other parts of the brain and the central nervous system, and even to the peripheral nervous system, which is where our brain and spinal cord connect to the rest of our body. And some of that is, that sensation, that's muscle control, but it's also things like, salivation, sweating. Those things are modified, those functions are modified or moderated by nerve input. We call that the autonomic system. And there's, and you can kind of think of it as the automatic system, or the autonomous system. So these are things you don't think, I want to sweat, or or I need to make more saliva. These things happen and kind of as reflexes to stimulate. And it's the same thing with your gut and your bladder control. And when the control from up top, from the brain, is different or changing because of something like Huntington's, then the control over these organs changes a little bit too. They don't stop working, but maybe they're less regular. So there may be more constipation, or there may be more bloating, or changes or fluctuations in your appetite. So, you may feel, oh, I'm so stuffed, but I hardly ate anything, and I can't look at food right now. And then, a few hours later, you're kind of starving again because things finally got moving, and it's been a while since you've eaten. Or, the bladder reflex has become more hair trigger, or just is a little more erratic. And so sometimes you, out of the blue, oh my gosh, I got to go to the bathroom, and I got to go yesterday. And you get there, and there wasn't very much in the bladder to begin with. And then 15 or 20 minutes later, oh gosh, I got to go again. Those things, that's kind of that overactive bladder type symptom. And we do sometimes see more of that, or just maybe a little more trouble balancing between urge and holding off the urge or controlling the urge. So there's a few different things, and frankly, often enough, those kinds of symptoms could respond to the medications that are out there already for those reasons that are marketed to the general public. So, and that's as important a reason as any to bring it up, because there may be a treatment for that, and we may be able to get it back under control, so that you're not having to look for a bathroom every time you get into go to somebody's house, you figure out where it is, or you go to a department store, and the first thing you got to find is, well, where's your restroom? So.
Is there a little bit of obsessive compulsive behavior in that as well, or is it mainly from the brain?
So I think most often it starts, I would say in the majority of cases it's a disconnect or a loss of good control over the function. But then once you start having issues, then we can fall prey to some of the other changes that might be part of our HD, which and in those cases, yes, kind of that compulsiveness or kind of getting a bit obsessive about it, and then it becomes kind of doubly debilitating or disruptive, because not only are you having the symptoms and the inconvenience of that, but then on top of it, you're not able to step away from the worry about it or the obsession, and it sort of takes over thinking about these things.
So what is actually happening in the brain when this is going on? Are there aggregates in the brain? Is it the neurons that are being damaged? What's the physiology happening?
Well, so we know we have the trinucleotide repeats, and it is sort of, while there are still some answers that we don't have for exactly what the Huntington gene is supposed to do normally, or all of its functions. But we know that when someone has HD, that for a number of reasons there is a premature loss of certain types of neurons, and particularly the motor-oriented neurons in the caudate nucleus. And we kind of think of the basal ganglia as a motor circuit, but in fact it's really a behavior circuit, where part of it is motor, but some of it is also emotion and decision making and those things. And so what you have is, it's like a a circuit that's maybe that over time is running at maybe 60%, 50%, 40% efficiency. So because there just are fewer neurons and fewer connections to keep the circuit doing what it's supposed to do. And so, and part of that is, when we're at rest, we aren't completely at rest. There are extra movements that pop up because because the muscle control isn't at balance. It's kind of like, imagine a car with its timing is off and the engine is misfiring even just as you're sitting there in the driveway.
Good analogy.
Yeah, and you're getting, so you're getting these extra signals. But then this is also supposed, part of the other things that the circuit does is it helps manage our decision making. So we know that things like, for certain types of decisions, it plays a role in kind of making us stop and say, oh, all right, is this really the right choice, or do I need to double check? I could do A or I could do B. At first glance, they kind of look like they're both reasonable, but maybe if I just waited that extra half second, I'd realize, like, oh, actually, B might not be such a good idea. I should do A. And so that gets to that thing we call impulsivity, and it has to do with connections from this circuit to the frontal lobes, which are kind of where our executive functioning is. And so that's part of the process. And then, you think of our whole nervous system as everything's interconnected to one degree or another. And if this sort of, I've always likened the circuit to kind of it's like a mix between an automatic transmission or something like that, and kind of an autopilot. You kind of have all this information stored about how to move or do things that you don't have to consciously conjure up. You don't have to think about what muscles are tense or relaxed when you're sitting up, or how to lift your foot up and put it back down when you're walking. And when this isn't working, suddenly really simple stuff like that gets very complicated. It's like, oh, why am I losing my balance? Why are these things happening? Because that governance isn't there, and that autopilot isn't doing its job all the way. And that's very frustrating. And it's something, we see this not just in Huntington's, but in Parkinson's and other Parkinson's-like disorders, and because it affects a different part of the circuit, but it's the same circuit nonetheless. And so that's something that, again, I think, especially for us movement disorders, we're very attuned to that concept that, these are things that a lot of this is function that we haven't had to think about. And now when that little assistant is sort of taken away from us, it becomes very awkward and very difficult and kind of very exhausting to try to do normal everyday tasks. I don't know if that answered everything, but it's sort of a lot of how I look at it.
And it also brings up more questions.
Of course.
Which is why you're here. But I did have an HD community member ask a question. Her HD person is having a lot of skin itching and skin sensitivities. Have you heard of that in HD?
I think it isn't terribly common, but it's certainly not unheard of, and it may have something to do with some of the autonomic changes. So people can get kind of almost like hot flashes or things, or or cold sweats, and so it wouldn't be entirely unheard of to also have kind of flushing and irritation or itching. We know sometimes, again, when the autonomic system is affected, you can have sort of almost some seborrhea like skin changes. Now, of course, the other thing you have to think about when I hear itching and irritation of the skin is, are they on a new medication? Have they started any medications prior to these symptoms coming up? Could it just be maybe a little bit of a medication reaction and something's not agreeing with them? So you always want to think about those things too.
What is so should that person then go back and check the medications to see if there's new medications?
I would definitely double check and make sure, within the first, maybe, is there anything new or even have any of my old medications been increased, say in the month or so before these symptoms started, assuming that they're kind of new symptoms.
Yeah, I've actually had some issues with drug brands with my own HD person. Specific generics may also play a role in the, skin irritations or stomach problems or other symptoms.
Yeah, certainly. I think in general, generics are very good and work well for most folks. But sometimes, because it's a different manufacturer, it's a different factory, they may use different fillers, different, coloring agents for the tablet. And sometimes, it's not that you're reacting to the active ingredient, it may be what they made the pill with that maybe is better tolerated for one and not so well tolerated for the other. And to be, for sort of full disclosure, I've actually had folks who have had reactions to brand names of a drug and the generic was better tolerated, probably because of the same thing. It's just a matter of sometimes it's just, whether it causes some GI upset or some inflammation or irritation, or sometimes it dissolves differently and you feel like the medication, hits you differently. I've had that as well. Again, not super common, but it can happen, and you're not out there just because you think, gee, it's the same drug, but it's a different manufacturer, and I feel like this is a different drug now, and that it can happen.
I would also want to ask if maybe there's any changes in maybe laundry soap or the clothing that they're wearing, or the shampoo or soap that they're using on their bodies, that kind of thing. But for example, if that person, say everything else checks out and the drugs check out, what could they actually do to help a person that's having severe itching problems?
So, and that is, itching can be a really, a very frustrating issue. And we'll run into it sometimes occasionally with some of our Parkinson's patients too. I find that oftentimes it may be, when all the other things have sort of been ruled out, it may be related also to immobility, so contact points or, areas, or like, the waistband, the areas that maybe get hotter or maybe get a little sweatier and hotter are more prone to it. So if it's sort of that situation, you can identify, well, gee, these are like, skin folds, contact points that, so it's kind of like a contact rash or heat rash kind of thing. You treat it a little bit like, sort of like a diaper rash, I would say you want kind of like the heavier kind of water occlusive creams or ointments, Desitin, even something like that. And you want to make sure that you get it nice, that, you know, after a bath, you really get your skin nice and dry and clean, and then you apply something like that. Otherwise, you know, if it's more of, you know, if it's more kind of almost like a seborrhea or a dry, you know, I mean, we're here in Arizona. Even if you're at altitude, sometimes at altitude you get drier skin, even though it's not as hot. You know, moisturizing is number one.
Yeah.
There can be, if it's a scalp issue, some of the medicated shampoos can be very helpful. You know, even if there isn't, say, a lot of dander or something, but just the redness and irritation there. And occasionally, you know, a little cortisone cream. If it's, you have to always be a little careful with cortisone cream. You can't smear that all over yourself, I think, but you know, kind of selectively, if it's kind of a few small areas. You don't run across it too often, but you know, usually those are the kind of the list of kind of things that seem to be most helpful. Occasionally, if it seems to be, if there seem to be other, like, you know, congestion and runny eyes, and maybe it's related to more of an allergy thing, one of the antihistamines, you know, and you have to watch for sedation and things like that with those, but those can also be potentially used.
Is Benadryl a good kind of go-to drug for antihistamine?
It can be. I think of all the things out there, Benadryl is, you know, it's probably the most sedating antihistamine, and you always have to sort of weigh that in. You know, sometimes, you know, certainly a lot of advertisers, companies have, you know, in the over-the-counter market have tried to take advantage of the fact that Benadryl, you know, makes you tired. So they put it in, you know, Tylenol PM, and, you know, and a lot of the over-the-counter sleep aids are really just, you know, an analgesic and Benadryl, which is diphenhydramine. And so that, you know, so Benadryl we kind of think of as being pretty benign, but there are some studies that show people who are taking Tylenol PM every night can have more memory problems and more other cognitive issues than folks who aren't taking those things, even if they're both having sleep issues. That there may be some things about being chronically on something like Benadryl that maybe outweighs that benefit. So
you mean under normal circumstances,
right?
Yeah.
So the thing you want to make sure is just, boy, am I trading off a little less itching for less interaction and less, you know, being less alert and you know, losing out on quality of life in a different way. I think the, you know, Claritin, which is, I think, loratadine, it works well also, and is probably the least sedating and is available over the counter. And gosh, Zyrtec, and I can never remember what Zyrtec's generic name is also probably a little stronger or a little more potent as an antihistamine than Claritin, but it's still probably less sedating than Benadryl. You know, Benadryl is good because it's probably the cheapest by far because it's been around so long, and you can actually take a fairly broad range of doses if you need to. So I would say, gosh, if it's really acute and severe and it's just driving you nuts, it doesn't hurt to take Benadryl for a day or two to get it settled down. But if it's more of a chronic thing, you may want to consider one of the newer over-the-counter antihistamines.
Is there co-cometic with Benadryl? Issues with other medications?
In terms of interactions?
Yeah.
Only in the sense that you know, if you're taking something like maybe clonazepam for REM behavioral disorder, like, for yelling out in your sleep or for those things, you're going to get a little extra sedation out of the two.
Okay.
I think other than that, there aren't any major interactions or say, like life-threatening type of interactions that we would typically be concerned about. It's more, it may enhance sedating effects of anything else that you're taking.
So should we be checking their O2 saturation on that?
I think as long as you're mobile and say, if you're talking, you're able to communicate well, those folks I would not worry about. Maybe if somebody's more bedbound and maybe has had some pulmonary issues, you might want to be a little more cautious. There's definitely nothing official to say you need to, but I would say, that's probably one of those things where you're covering your bases by just double checking. It's kind of smart.
Checking pulse and respiration.
Yeah.
And,
if you happen to, if you already happen to have like one of the little home pulseox things, that's not a bad thing, especially if it seems to be causing a lot of sedation, it's more for peace of mind, I think, in most cases. It's certainly not like giving someone, say, Valium or lorazepam or something like that, where there's more of a direct potential for suppressing, breathing drive. But yeah, I think when somebody maybe with more advanced symptoms and who's maybe more bedbound and doesn't have very good mobility or very good lung volume to begin with, anything that can make you sedated could potentially impact your oxygenation. So
now, with movement disorder, do you work with lung function as well, or do you refer out to pulmonary?
We usually refer out for concerns if we have concerns about lung function, and typically we work with the pulmonologist, or sometimes we'll go through the internist if they're comfortable initiating those things, and thankfully it doesn't come up as often as one might think it could, but it does sometimes come up in Huntington's and HD.
Maybe more in later stage.
Yeah, and then usually it seems like, I would say, at least in our experience in recent years, if it's coming up, we've been gradually getting folks plugged in with different services and support so that it is, it seems to happen pretty naturally that, okay, we need to it'd be a good idea to get some pulmonary testing, and, because maybe the home health nurse is picking up some low pulse oxes on their visits or something like that. So we try, I think, most of us who are specialized in these things, we try to sort of get folks plugged in with services so that we're, if we can, as much as we can, we have things in place in anticipation rather than in response to a problem.
It kind of takes a team, right?
It definitely does.
It takes a village.
It does. And sometimes it feels like, we could use 2 villages and we still be accepting more. But this is a 24/7 issue, and I think the other big thing is, it's the caregivers. I have this conversation more often than I would like to, but it's an important one because I think it's easy to become overwhelmed because I tell folks, an ICU nurse has, years of training, schooling, practice, and they still work 8, maybe 10-hour shifts, and then they've got somebody that takes over for them. Nobody can do this 24/7, day in, day out, and not have somebody backing them up or
So
supporting
tell
them.
us, what do you think the perfect team looks like as far as like an all around, how do we take care of everything for the HD person?
So in a perfect world, I think, there we have the family, we have the primary care doctor, we have whatever other specialists in the neurologist or movement disorder specialist, and then we have some form of either whether it's through home health or some other agency, some not just nursing assistants, but I think that's very important. So number one, nursing assistants, but also just some plain old physical help, which could be an aide, could be what have you. It's not always easy to arrange, but talking about, ideally, and a case manager, which is really kind of the person that knows, okay, here's the system that you're, between whatever your coverage is and the community has. Here's the person that knows how to navigate this and is interacting with you and your family periodically to see, all right, are your needs being met? Have they changed from the last time we talked? Is there something new? Whether it's oh gosh, you really could use a hospital bed or a bed with railings, or you could use, something to help you and your family get you in and out of bed or get it to the bathroom, or do you have, does your caregiver have enough support so that they're comfortable going to the grocery store on their own or taking a nap on their own and like that, and
Yep.
yeah, because I think as a caregiver, the thing you dread is that the half hour you step out of the house, you get a call from that something's happened while you weren't there, and I think that really weighs heavily on a lot of caregivers, and
A lot of stress.
and yeah, and we shouldn't feel that alone,
Right.
where that's we feel like those are the choices we've got to make, and
Good to find
so,
ways to relieve that stress for the caregivers.
yeah,
Where your passion is.
and it's different in every community. I think and by even what your own personal resources are. So, but thankfully, there's several agencies, and I can't think of the name now, but I think Sarah knows. Would be able to get us the contact. But there are a couple of groups that all they do is actually just help refer people to different, whether it's home health or it's a private group that does things, or a volunteer group that provides.
We do that here too.
You guys, that's right.
Yeah.
So yeah, and
it's good to have a lifeline, so to speak.
yes, yeah. And so that's where agencies, like yours, are so important.
Yeah.
And there are, the hardest part I think is knowing where to start, and that's also where whether it could be the internet, it could be your movement disorders doctor, it could be. But
right.
Finding those names so that they find you and they find Sarah, they find these other groups.
So we know that you, as a movement disorder specialist, as a primary physician, can order home health. But when do you know when home health is needed?
Well, I would say, I think, it is. I think the more of a role that is you start to find, or in whether you're the caregiver or the patient, but that you find that you and your primary person are are interacting more and more as caregiver and patient as opposed to, you know, family member or spouse or those things. I mean, that those, and it's a gray line. I recognize that, you know, but that as you find that, you know, even if it's, I would say, gosh, you know, if it's 25 or 30% of your interaction is more caregiver, you know, oriented than yeah, than partner oriented. You know, it's already reasonable to be thinking about that. I think the mistake that happens is we really don't think about it until we're
That's
exhausted.
what I'm trying to get at is,
And then we feel guilty, like, oh, I failed. No, you're doing an
for a
impossible. I
crisis.
always try to tell people, no, you've been doing the work of 3 people and trying to be a spouse or a mother or a sister, and that's nobody can do all that. So I think, you know, whether maybe the real practical thing is, you know, that first time you start to think, whew, I don't know if I can keep all this up, you know, even if it's just for half a second. And talk to your doctor and say, you know, I think we're doing, even if you say, gee, I think we're doing okay, but I have moments. That's, you know, that's a much better time to kind of have that conversation
Good
and
advice.
explore those things than when you come in and you're like, help, you know, the white flag is up, you know, because sometimes something happens to one of you before you get to that, and or that, you know, or it's some catastrophe, and that's the white flag moment, and we don't want that to happen because neither of you deserve it, or none of you.
I'm totally an advocate for that because I do see a lot of caregivers in crisis.
Yeah.
And I hate to see that because it really doesn't have to be that way, you know?
Yeah, and unfortunately, and you know, it's still, it almost, I won't say, you know, the majority of the time, but boy, a big chunk of the time, that is still how we get to, gee, we need to initiate, you know, home health.
Yeah.
And I think it's lots of factors. I think none of us feels really comfortable with, you know, sort of giving up control of our home to somebody else. And you feel, you know, you're worried that, gosh, you know, I haven't been able to fix this. So maybe I'm going to be judged because I'm not doing a good job, when really
I'm not a super mom.
doing an incredible job. It's just no one person can do this job, you know, and there's lots of different reasons why I think people are hesitant sometimes. And I think that's maybe the biggest, you know, if I could get people to change one thing, you know, at home, is just keep an open mind to getting some help, you know, even if it's just somebody comes twice a week to, you know, or, you know, and just is there so that you can do other things and recharge your battery and worry about the groceries, or go to your own doctor's appointment and things like that, just so that it breaks things up. And it, you know, I think as a, you know, as a person, as the patient, or as a person with HD, I think it's a relief for them, because you don't want the person you love, you don't want to feel like you're the thing that anchors them to the house, or that you're, you know, it's already stressful to feel like, to know that you're not able to do or help as much as maybe you used to. And so knowing that there's somebody else that comes and helps, it takes a little burden off, I think is even if you're a little nervous about having someone coming into your house, I think ultimately it's almost always a big relief.
Mm-hmm. What about hospice? Now, I know some hospice agencies will only see you or take a case if you have 6 months to live. But with Huntington's, it's such a long-term disease, and once a person is bedbound, would that be a good time to call hospice for help?
I think absolutely, because we know what when as mobility goes down and the more stationary you are, unfortunately, the risk of other more catastrophic things, pneumonia, blood clots, things like that are, they creep up. And so there's certainly you're in a more vulnerable situation at that point. I think too, it's important to recognize that I think, one of the things that maybe, that Medicare has gotten right over the years is they've recognized that there's a sort of gap between, hospice and end of life and kind of more extended disability and palliative care. And so that now that there is the sort of, and I can't remember the specific, whether that's the term or if it's sort of, but there's an intermediate level now sort of between true hospice and sort of, and not having, and only home health or something like that. So that in several of the hospice groups, in Arizona offer both levels, not all, but several. And I can't remember if it sort of respite, but I think it's really more palliative care is the term.
Yeah. We have agencies like that here in California as well, where they are doing home health and hospice. So then you have that intermediary time frame of palliative care that needs to happen.
Yeah, and I think it's good because you're not sort of under that 6-month time frame where things, and I think there's a little more flexibility if something comes up that is sort of unexpected and maybe treatable. You need to go to the emergency room or urgent care or get something taken care of, and you didn't have to then opt out of hospice and then and then you worry, gee, will I be able to get the support again if I do.
Yeah.
So that is getting better. That's one area. There are lots of things that may need to be fixed in healthcare right now, but that's one really good addition.
Right. Gosh, we've been talking for almost an hour. Can you believe it?
Oh wow! Yeah. It's an important topic, and it's time flies.
Let me see if I have any more questions. I didn't see any come in, but I know I've talked with several HD moms that either their JHD patient or their HD patient has had skin issues. And my own personal issue with my son is the hot flashes, the not able to control his temperatures. If it's too hot, it's really hot. If it's too cold, he's really cold. That thermostat is kind of broken.
Yeah, and that and it doesn't sound. You think, well, gee, what's so bad about that? But that can be really frustrating and very uncomfortable. Especially if it happens multiple times a day, or you can't, or it happens out of the blue. And I see it more often, in some of our Parkinson's patients, but I've definitely seen that as well in our HD patients. There are, again, these would be things, they're what we would call off-label use of medications, but sometimes there are medications like gabapentin that have some studies that show that they may help with certain kinds of hot flashes. They've been looked at menopausal hot flashes, and they may be helpful, anecdotally may be helpful sometimes in hot flashes in conditions like Parkinson's and HD. There probably are a few other things that sometimes, some other medications that sometimes can be helpful. And again, I think sometimes it's the other way around. It can be, there are certain medications can aggravate that. And it's always good to double check the med list and you can be your best detective by thinking about, well, how long have we been taking this? How long have we noticed these new symptoms or these symptoms? And does it line up at all with any, anything, whether it's a dose change or a new medication, or even stopping? Maybe we stopped something and we didn't realize that was actually helping to suppress the symptom, and now that we're not taking it, we're having the symptoms. So
yeah, drugs can have a big effect on our HD
yes,
people, for sure.
Yeah, intended and unintended. And
yeah. Well, I think we should wrap this up. So, Dr. Samanta, you have to get back to work, and thank you again. You're a sweetheart for spending this time with us. Cool. And thank you, PMD Alliance and Teva, for providing this platform for us. Every Tuesday, Lunch with Docs HD, every third Tuesday of the month. So everybody have a great month, and we'll see you next month.
Thank
Dr.
you.
Samanta,
Thanks for
take
having
care.
me.
Thank you.
Bye.
Bye-bye.